Hello everyone, and welcome to our CLL Care educational series of webinars that are meant to provide hematologists from all over the world with the latest insights into CLL management. Today, it is my great pleasure to welcome you, our speaker, Dr. Philip Thompson, who is a renowned hematologist specialized in chronic lymphocytic leukemia. He earned his medical degree from the University of Melbourne, where he completed his residency and hematology training. And currently, he is an associate professor of hematology at the Peter MacCallum Cancer Centre and Royal Melbourne Hospital. And today, we are truly honored to have him share his expertise regarding resistance in CLL. And before we start, I just want to remind the audience that you will be muted for the entire duration of the webinar. But we encourage you to use our chat box in case you have any questions. And Dr. Thompson, he will reply to them at the end of the presentation. So, Dr. Thompson, thank you very much again for accepting our invitation. And please feel free to start whenever you are ready.
Thank you so much for the kind invitation to speak this evening, and good evening or good morning or good afternoon wherever you are in the world. It's late evening here, and this is a photo of me from before I had children who aged me dramatically. So these are my disclosures. So objectives tonight really are to understand resistance mechanisms in CLL that develop during treatment, and then I'm going to go over some strategies for how we can manage patients when resistance emerges. And we're talking about some newly emerging treatment strategies which are either coming into the clinic or in advanced stages of development. So I'm not going to belabor the point here, but really we now have two main classes of targeted therapies that are in use in CLL. B-cell receptor signaling is a critical part of CLL growth and survival, and BTK is a key element of that. So we now have three covalent BTK inhibitors in the clinic, which are highly effective in CLL treatment. BCL2 overproduction occurs in the vast majority of CLL patients. This is an anti-apoptotic molecule, and targeting this for inhibition with BCL2 inhibitors, of which venetoclax is the only commercially available drug, also highly effective at treating this disease. PI3 kinase inhibitors very rarely used outside of really desperate situations, mainly now because of toxicity profile. And then we're going to talk very briefly about immunotherapy, but really CLL, like other B-cell lymphomas, can be successfully targeted by T-cell redirecting therapies. CAR T-cells have been used since 2011 for CLL and clinical trials, and we now have an approved product with liso-cel in the United States targeting CD19, and we have a number of CD19 and CD20 targeting bispecifics that are in clinical trials. So, how do patients become refractory? And in particular, I want to talk a little bit about this concept of double refractory patients, which really refers to patients who have failed both a covalent BTK inhibitor and venetoclax. And there are a number of different pathways to getting to this double refractory status, which may include initial treatment with chemoimmunotherapy, depending where you are in the world. The definitions are a little tricky. So when you take a continuous BTK inhibitor, if you progress on therapy, clearly you're resistant by definition. However, with venetoclax, where we're mostly using time-limited therapy, it becomes a little bit of a challenge as to where do we draw the line? When do we consider a patient refractory? So if we give time-limited treatment and a patient progresses 24 months later, are they refractory? Do you have to retreat them and show that they progress on therapy for them to be refractory? A little bit tricky, but a commonly used definition essentially is that patients progress within 24 months of discontinuation of venetoclax. Now, if we go over to the right, there's the special case of combined frontline use of BTK inhibitor plus venetoclax. So ibrutinib and venetoclax approved in a number of countries for first-line treatment of CLL. And clearly, if you progress on therapy, which is a rare event, then you're double refractory. But we'll talk a little bit about resistance patterns in patients who progress after completion of treatment later. And I would argue that most patients who progress after treatment with this time-limited doublet therapy are not refractory, and I would not consider them double refractory without at least a trial of retreatment. So we'll move along into some of the data on resistance mutations. Now, ibrutinib was the first BTK inhibitor to enter the clinic, and it really dramatically changed outcomes for patients with refractory CLL. And these are pooled data from Ohio State University, where they looked at patients treated with ibrutinib on 4 prospective trials. The cumulative incidence curves on the left are representative of different reasons for treatment discontinuation. The blue is toxicity, essentially, so patients who had adverse events and came off treatment because of that. The yellow is Richter transformation, which you can see was predominantly an early event and likely reflected really high-risk biology in these multi-refractory patients that were going on these trials. And this pattern of Richter transformation has not been recapitulated in frontline treatment with BTK inhibitors in particular. The grey curve represents CLL progression, which you can see essentially occurs continuously with increasing likelihood the longer you're on treatment. The pie chart over on the right represents the causes of resistance in patients progressing with CLL, not Richter's. And what you see is that 72% of patients have a BTK mutation. So the blue part of the pie chart is BTK mutation alone, and the grey is BTK mutations combined with a PLC gamma 2 mutation. So PLC gamma 2 is downstream protein in the B cell receptor signaling cascade. So if you have an activating mutation in PLC gamma 2, you can potentially bypass BTK blockade. 20% of patients shown in yellow have neither a BTK mutation nor a PLC gamma 2 mutation. So this is a look at the pre-treatment patient characteristics and causes of discontinuation. So you can see that transformation events were driven by complex karyotype and MYC abnormalities, CLL progression by complex karyotype and 17p deletion. Patients who stopped because of toxicity, this was much more common in patients who were older and patients who were heavily pre-treated. So essentially, disease progression associated with high-risk genomics, not particularly surprising, and toxicity and was associated with older age and heavy pre-treatment. So frailer, sicker patients. Okay, so what are the actual? Let's delve a little bit deeper into the actual mechanisms of resistance. So the most common mechanism of resistance, as I mentioned, BTK mutations. Where do they occur? Well, they occur in this cysteine 481 residue, which is within the ATP binding pocket of the BTK enzyme, and this is the site that ibrutinib binds, and in fact is the site that all covalent BTK inhibitors bind. So mutations in cysteine 481 will produce pan resistance across covalent BTK inhibitors. So what happens when you have a C481 mutation, most predominantly a C481S mutation, is that you no longer get covalent binding, and instead you have a competitive binding to the ATP pocket. And covalent BTK inhibitors have really short half-lives. So when you no longer have covalent inhibition, you have active enzyme for the majority of the 24-hour dosing interval. So there have been a number of studies after the original report kind of looking at BTK and PLC gamma mutations in patients treated with BTK inhibitors. And one thing that's been observed is that quite a number of these mutations, when you look in the peripheral blood, are actually subclonal, and sometimes you may only find the mutation in a relatively small fraction of the cancer cell population. So what does this mean? Does this mean the mutations are actually not that important and they're an epiphenomenon? Well, probably not. And we'll get into why that's the case in the next couple of slides. But I also want to talk about some of the other resistance events that you can see. So I mentioned that Richter transformation tends to be a relatively early event in BTK inhibitor therapy. And the majority of Richter transformation patients actually don't have BTK and PLC gamma 2 mutations. They often have catastrophic genomic events, multiple acquisitions of multiple copy number abnormalities, chromatripsis, other events like that. So not single gene mutations explaining resistance. The other thing to say about BTK and mutations, they often emerge a long time before you actually develop clinical resistance. So when you do serial sequencing of patients, which has been done by Jennifer Woyak's group, you can detect these mutations many months, or sometimes more than a year, before you actually develop clinical resistance. And there are probably additional mutations which do occur, including additional chromosomal abnormalities that also contribute to resistance. But what you can see when you look at a single cell level is that there's actually remarkable subclonal heterogeneity in these patients. So this is a single patient who developed ibrutinib resistance after 34 months of treatment, and single cell analysis was done on the blood. And what you can see is, if you look over here at this phylogenetic tree, and I'm sorry, my this laser pointer doesn't seem to be working. You may not be able to see it, but essentially this phylogenetic tree in the middle of this slide shows that there are 6 different mutations present, with multiple different BTK mutations at cysteine 481, and 2 separate PLC gamma 2 mutations, and they're actually all occurring in different clones. So that partly explains why patients may only have low variant allele frequencies of a particular mutation, but they have multiple different mutations in different clones. But also, if you look at different compartments within the patient and sequence those different compartments, you actually see different resistance patterns. So if we look here at the bottom right of this slide, this is sequencing from blood, lymph node, and bone marrow, and you can see that the C481S mutation is present only 5% of cells in the peripheral blood, but 76% of the cells in the lymph node and 56% in bone marrow. So we always need to remember CLL is a multi-compartmental disease, and you can have spatial heterogeneity in the mutation pattern that you can see at the time of progression, and that's what's reflected here. In other diseases, people have looked at liquid biopsies, circulating tumor DNA, to look at total mutational burden. There's less data on that in CLL, in part because of the relatively low apoptotic and necrotic rate in tumor tissue, as well as because of course, the easy accessibility of circulating disease. So what about second generation BTK inhibitors? Are the mutation patterns the same as they are for ibrutinib? And the answer is partly yes, but there are some key differences. So these are data taken from a phase 3 trial comparing ibrutinib to acalabrutinib in relapsed refractory disease, the ELEVATE-RR study. You can if you look at the mutation patterns on the left for acalabrutinib compared to the right for ibrutinib. The ibrutinib, it was almost entirely C481S mutations, plus or minus other cysteine 481 mutations. You see one patient over here had an A428D mutation and L528W mutation. We'll hear a little bit more about those in subsequent slides. When we look at acalabrutinib, I want to draw your attention to the orange section of this column graph, and that represents T474I gatekeeper mutations. So this is distinct from mutations in the binding site of acalabrutinib, and these are important because they produce resistance to other molecules that target BTK, as we'll see later on. Likewise, zanubrutinib, also a second-generation BTK inhibitor, which is much more selective for BTK than ibrutinib. You can see, in addition to the C481 mutations, which dominate ibrutinib resistance, we see these L528W mutations as a frequent mechanism of resistance in these patients. So what's the significance of these different mutations? How might that impact our subsequent treatment? We now have multiple different ways that we can target BTK. So pirtobrutinib is a drug that's now approved by the FDA in the US for treatment of double-exposed CLL patients, and that's based on this single-arm Bruin trial. So it's an accelerated approval, and a number of confirmatory studies have been done, and the 321 study has now read out. But essentially, this molecule is a non-covalent a BTK inhibitor that does not bind to cysteine 481, although it does still bind within the ATP binding pocket of BTK. And critically, it has a very long half-life. So you can see there with single daily dosing, you remain above IC90 for the entirety of a 24-hour dosing interval. So this drug, interestingly, seems to stabilize BTK in a closed and inactive conformation. That's important because it not only inhibits BTK signaling, which is dependent on phosphorylation of Y223 residue, which is shown in the green section of the kinase diagram over there, but also prevents Y551 phosphorylation, which is essential for recruiting other kinases in this so-called scaffolding interactions. So this drug is highly effective in patients who've received a prior covalent BTK inhibitor. So in preclinical experiments, it inhibits cysteine 481 mutated cells, and also inhibits wild type BTK. And you can see here that the vast majority of patients had significant nodal reduction with an 81% overall response rate in previously covalent BTK inhibitor treated patients with CLL. And we saw similar response rates in patients who had also received a BCL2 inhibitor, which is shown over there on the right. And I haven't shown the data here, but actually, if you look at the presence or absence of BTK mutations at the time of starting pirtobrutinib, responses were equivalent whether you did or did not have a BTK mutation. This is progression-free survival. It's a little bit shorter if you're double exposed compared to if you're BCL2 inhibitor naive, so 23 versus 15.9 months, but still a very good option for patients who have double refractory CLL. So, does this drug prevent BTK mutations? Is this no longer an issue when we use pirtobrutinib? Unfortunately not. Really, I think when we use monotherapy targeting a single protein in any disease in oncology, we're going to produce resistance under selective pressure, and pirtobrutinib is no different. And this is from the original description of pirtobrutinib resistance mutations. It was published in New England Journal in 2022, and here we see quite a diversity of mutations in BTK. So you'll notice the absence of C481 mutations, which is one probably have predicted given the efficacy of this drug against cysteine 481 mutations and the fact that it doesn't bind to cysteine 481. But what we do see is numerous other tyrosine kinase catalytic domain mutations, and we already talked about the L528W mutation, which we see in zanubrutinib treated patients, and the T474I mutation, which we see in acalabrutinib mutated patients. So that's important to know that those mutations which we see with certain second generation BTK inhibitors will also produce resistance to pirtobrutinib. And so one other thing that is fascinating about these mutations is that they actually, a number of them actually result in an inactive or decrease or partially active kinase. So if you look at this Y223 phosphorylation, that's an indication, which is on the first line of this Western blot. That's an indication of BTK activity. So you see these A428D and L528W mutations completely aggregate Y223 phosphorylation. So essentially, these are so-called kinase dead mutations, whereas T474I is kinase active. But if you look at AKT phosphorylation and ERK phosphorylation, which is a marker of downstream signaling, they are preserved. So why is this happening? Well, this is this so-called scaffolding interaction. So the BTK that has these mutations, even in the presence of pirtobrutinib, is able to recruit other kinases and activate them, and therefore activate downstream signaling. And as you see here, pirtobrutinib can block AKT and ERK phosphorylation in wild type cells, but it cannot do so in the presence of these kinase domain mutations. This is just a larger analysis from the same Bruin trial with more patients, again showing all these mutations clustered in the kinase domain, with L528W and T474I being by far the two most common mutations that we see. But one patient with A428D mutation, and I'm highlighting that for reasons that'll become apparent later. So when we look at serial sequencing from baseline to the time of disease progression, many of these patients had BTK C481 mutations when they started therapy, and you can see those go down during therapy, whereas these other kinase domain mutations emerge during therapy. Now, it's important to remember that although these C481 mutations are decreasing in allelic frequency and in some cases become undetectable, I don't think we should think that they're gone completely. Next generation sequencing usually only has a detection threshold of around 1%. We can assume that these mutations are still present below the threshold of sensitivity. And if we were to say, stop pirtobrutinib and put patient back on a covalent inhibitor, I think that we would see relatively rapid reemergence of those C481 mutated clones. So we haven't fully restored sensitivity to previously used therapies. So just to summarize, patients on pirtobrutinib do clear their C481 mutated clones, but we see others emerging, particularly T474I and L528W mutations. Important to remember that those particular mutations might be shared resistance mechanisms with acalabrutinib and zanubrutinib, respectively. There are still a number of patients who didn't acquire BTK mutations, and the causes of them becoming resistant are not clear. And so just on the topic of shared resistance mutations, this is an anecdote from a patient that was treated at our center on a zanubrutinib study. It became resistant to zanubrutinib, and you can see on the bottom right, if you look at the baseline mutational profile, this patient had 3 different C481 mutations at a couple at relatively high variant allele frequencies that are shown in blue, and shown in red is this L528W mutation that was present at a relatively low VAF. And then when he started pirtobrutinib, you see the C481 mutations disappear, but this L528W mutation grows out, and the patient becomes resistant to pirtobrutinib in a relatively short period of time after an initial response. So this would be something that would be important to know prior to choosing your next line of therapy if you happen to have multiple options. So how do we manage all these mutations? Well, the most obvious way is simply to switch to venetoclax, which obviously targets a completely different cellular process in BCL2 overexpression and apoptosis. But we also now have another way of targeting BTK, which is bifunctional degrader molecules, which result in degradation of the entire protein. And then, of course, we have T-cell redirecting therapies, which by targeting surface molecules actually are completely agnostic of any mutation that the patient may have. So the first degrader BTK degrader to be tested was NX2127. Essentially, this is a heterobifunctional molecule, so it binds BTK and then it binds to an E3 ligase, which results in polyubiquitination of BTK and then proteasomal degradation. You can see here on the bottom right that the drug is able is effective in vitro against C481 mutations, as well as all of these tyrosine kinase domain mutations that we saw emerge in patients treated with pirtobrutinib. So one would predict that a pirtobrutinib treated patient would probably respond to treatment with this BTK degrader. So NX-2127 isn't going further in clinical development, but there are two others that are. So BGB-16673, the Cadence study, now has large numbers of patients with CLL that have been treated, and the results were presented at ASH last year. So again, same concept, degradation of BTK induced by coupling the enzyme to an E3 ligase, which we don't know the E3 ligase that this molecule uses. In vitro, again, all of these mutations that we see with covalent and non-covalent BTK inhibitors are sensitive to the drug. And we saw in a very heavily pretreated population of patients, we saw very high rates of clinical activity. So I'm highlighting the 200 milligram dose because this is probably going to be the dose that goes forward into more advanced stages of development. But there was overall response rate of 93% among patients that received this dose on the trial. When we look at different biologic subsets of patients, you see that double exposed patients had an 86.7% response rate, and triple exposed patients, so patients who'd had both a covalent and a non-covalent BTK inhibitor as well as a BCL2 inhibitor, had a 58% response. So a little bit lower than the double exposed patients, but small numbers at this point. And all these patients with high risk genomic features like complex karyotype TP53 abnormalities, PLC, gamma2 and BTK mutations, all showing responses. So if you look at the swimmer's plot, what I've done here in red is highlight the patients who were triple exposed, and you can see that a number of these patients have actually had durable remissions on therapy with BGB-16673. There are some remissions that are now out beyond 2 years. And really quite a favorable progression-free survival curve for such a heavily pretreated population of patients. So this molecule is in ongoing phase 2 studies in a number of histologies, and there's a phase 3 comparative CLL trial which is in advanced stages of planning, which we can look forward to. The NX-5948 is another BTK degrader which had preliminary data presented at ASH. Similarly, in vitro, active against this full range of mutants that we see, and you can see from this waterfall plot, highly active drug, and this was active regardless of BTK mutation patterns, TP53 mutation, all these kind of usual suspects for high risk disease. Intriguingly, also seemed to be active in patients who had central nervous system disease, which is usually an exclusion criterion for many clinical trials. So are these drugs going to prevent emergence of resistance? Well, I would say conceptually very unlikely. They have, first of all, the drug has to bind somewhere to BTK, and this is largely around this A428 residue, and indeed A428D mutations have led to resistance to both BGB-16673 and the Nurix compounds in vitro and in vivo. So I think we're going to see this mutation emerging in patients that are treated with degrader molecules. Thankfully, it's not a mutation that we commonly see with either covalent or non-covalent BTK inhibitors, but we are going to see resistance emerging to degraders. And the other question, of course, will be: are we going to see non-BTK dependent mechanisms of resistance emerging for this class of drugs, given the very potent degradation of the molecule? All right, so moving now to venetoclax. So what are the mechanisms of venetoclax resistance? So venetoclax initially was used as continuous monotherapy, and the largest single study looking at venetoclax monotherapy was a study which enrolled patients that had had a previous B-cell receptor signaling inhibitor, so either ibrutinib or idelalisib, but the majority of patients had been treated with ibrutinib. You see 91 patients here on the left. They were a really high-risk group of patients, very heavily pretreated, high proportion of 17p deletion. And you can see here relatively favorable progression-free survival for this really high-risk group of patients over 2 years for prior ibrutinib treated, and well over 3 years, actually over 3.5 years for prior idelalisib treated patients. So this gives us a great opportunity to really look at double refractory patients and what are the mechanisms of resistance here. And you can see that a large number of patients had BTK mutations at the when they went onto the study. And if you look at this column, at this row, with BTK mutations, the grey represents the patients that had a BTK mutation and it persisted during therapy, whereas the light cyan color shows the few patients that actually had the BTK mutation disappear during therapy. And then if you go down to the bottom, we see BCL2 mutations, and they were seen in 30% of patients at progression. So this is a lower proportion of patients than develop BTK mutations during BTK inhibitor therapy, but still a reasonably common mutation that develops during resistance when we treat patients with continuous venetoclax, which is, of course, not how we mostly use this drug. Again, these are mostly subclonal mutations. The most common one is the G101V mutation, which leads to about a 50-fold decreased binding efficacy for venetoclax to BCL2. One thing that really important to bear in mind here is that this is patients treated with continuous venetoclax, and I think when we look at the time-limited venetoclax treated patients, this is going to look a bit different. So 30% of patients with BCL2 mutations, clearly there are other things at play here. And a number of groups have looked at this, but I thought this was a particularly elegant study that came out of the Walter and Eliza Hall Institute, a group led by Andrew Robertson, David Huang, and Rachel Tyson. And they did single cell analysis with multi-omic approach to kind of really tease out what the venetoclax resistance mechanisms were in patients. And this is a one patient, and this is their RNA sequencing data, looking at different looking at the gene expression profile of these patients. This patient did have a BCL2 G101V mutation, but as I mentioned, this is usually subclonal, and you can see from this scatter plot here that the transcriptomics of this look very different in the BCL2 G101V mutated patients compared to those without G101V mutation. But clearly the ones without the mutation are also resistant to venetoclax, and they've shown multiple different mechanisms of resistance for those patients, including loss of pro-apoptotic protein, functional pro-apoptotic proteins like PMA IP1, which is a BH3 only protein, and overexpression of anti-apoptotic proteins like BCL2L1, BCL2A1. If we look at the genetic sequencing in these patients, we see BCL2 mutations in a minority of patients, and actually loss of pro-apoptotic proteins like BAX and NOXA and PMA IP1 is actually rare as a resistance mechanism. But the other thing that we see is upregulation of other anti-apoptotic molecules, and MCL1 is a big player here, as well as a number of other proteins that you see there. But I want to really drill down onto the MCL1 in particular, which you can see here on this this violin plot down here, which shows this overexpression of MCL1 at progression in the majority of patients. These black rectangles just below the violins represent patients who have amplification of 1q, which is the location of MCL1. So that doesn't explain MCL1 overexpression in the majority of patients. So MCL1 is a target that people have been trying to drug for a number of years now. Clearly because of data like this. Unfortunately, it's expressed in myocardium, and it appears to be important for heart function. When you give people MCL1 inhibitors, they get major troponin rises, and this is completely hamstrung the development of MCL1 inhibitors in CLL. But I think in the future, this will be figured out. Maybe we can use degraders that use an E3 ligase that's not expressed in cardiac myocytes. Maybe we can modify the small molecule so that it's only taken up into CLL cells. There'll be lots of different ways that we can further explore this, but unfortunately at the moment, no MCL1 inhibitor on the horizon as much as we might like to have one. And I'm just going to skip over this in the interests of time, and move now to time-limited venetoclax. So the Murano trial was the study that led to venetoclax rituximab approval. It's a randomized study comparing Ven-R to bendamustine and rituximab. I'll point out that only 5 patients on the Ven-Ritux arm had prior ibrutinib, so this is mostly a previously chemoimmunotherapy treated population. This study clearly showed a benefit for Ven-R versus BR, which is not really what I wanted to show. What I wanted to show was the resistance mutations. You can see here that unlike the continuous venetoclax treatment data, which I showed you previously, we're not seeing any BCL2 mutations on NGS with a 1% sensitivity. We're also not seeing, we saw one BAX mutation, and we're not seeing any PMAIP1 mutations. So really none of these kind of genetic causes of resistance seen at progression in these patients on Murano. Now, bear in mind, this was patients who were subsequently retreated with venetoclax and rituximab. So they were patients that responded well initially, and they weren't patients that had resistance emerging on therapy. And overall reasonable responses to retreatment, median PFS of almost 2 years. So retreatment certainly can be an option for some patients after time-limited venetoclax based therapy. One other thing that's been done from this trial is they had serial MRD analysis on a large proportion of the patients off after they completed 2 years of therapy, and they were able to have deep sequencing done on 42 patients who had more than 1% MRD in the blood. And they did that by digital droplet PCR, which has a limit of detection of 0.1%, looking specifically for BCL2 mutations. And they found 4 mutations in these patients with high-level MRD, so still a really small minority of patients. And actually, fascinatingly, a couple of these patients responded to retreatment with venetoclax or venetoclax rituximab, but really tiny amounts of data for those patients. So I will mention, I don't have any slides for this, but there are novel BCL2 inhibitors that like sonrotoclax, which in vitro at least seem to work against G101V mutations, which is the most common BCL2 mutation emerging under venetoclax treatment. And there have been patients treated on sonrotoclax trials who've had prior venetoclax. So it'd be interesting to see what those data look like. What about venetoclax after BTK inhibitors? Well, venetoclax rituximab does work after BTK treated CLL. I mentioned on Murano, very few patients treated with BTK inhibitors. So we're sort of in the realm of retrospective data here, but this was a 48 patient analysis from a number of Australian centres, which showed a median progression-free survival of just over 2 years with venetoclax rituximab in a heavily pretreated and high-risk patient population who'd had prior BTK inhibitors. So it certainly works, but the remission duration is much shorter than we saw with the Murano patients who hadn't had a prior BTK inhibitor. The Mayo Clinic group has also produced some useful data in this regard. And I'll draw your attention to the bit over on the right-hand side. This is patients who were chemotherapy naive, had frontline BTK inhibitors, became resistant, and then had venetoclax treatment. And you see a median progression-free survival, a 2-year progression-free survival of 59%. So this is significantly lower than we would expect after with venetoclax rituximab after chemoimmunotherapy. So it seems like patients that progress on BTK inhibitors are a bad group of patients, with high-risk disease. And that's just something to bear in mind when you see these patients in the clinic. They are high-risk patients, even if they haven't seen chemoimmunotherapy before. So to summarize, we can treat with a second class of targeted agents after failure of a first targeted agent. Responses, however, are less durable than when patients are targeted agent naive. We can go from BTKI to VEN. We can go from VEN to BTKI, although there's quite limited data with venetoclax obinutuzumab first, followed by BTK inhibitors. Just always bear in mind that targeted agent refractory patients, so people who progress on therapy, do much worse than patients who become intolerant of a targeted agent. And so you have to be more vigilant about these patients. So I'm going to briefly touch on frontline doublet therapy, so ibrutinib and venetoclax. This is available in Australia. It's available in the European Union. And it's based on the GLOW trial, which enrolled older patients. But I want to look at the Captivate trial, which enrolled younger patients and wasn't the basis of the approval of this regimen. But mainly because there are some really nice mutation data that I wanted to talk about. So essentially, this is a fixed duration approach: three cycles of ibrutinib followed by 12 cycles of combination therapy. There was an MRD adapted cohort, but we'll be focusing on the fixed duration cohort. And the key element here is that when patients progressed after fixed duration therapy, there were 40 patients who had sequencing for BTK and PLC-gamma2 mutations, and there was not a single one. So unlike patients who are getting continuous BTK inhibitors, where we see 75% of them that will have a BTK mutation, and another 8% or so that'll have a PLC-gamma2 mutation. Here, we're not seeing any. So with combination therapy given for a limited duration of time, we're not seeing these BTK mutations. There was one BCL2 mutation, and this patient, as you can see over here on the right, although with limited follow-up, at least did respond to retreatment with ibrutinib and venetoclax. But what about retreatment with BTK inhibitors in this population? Well, you can see here, most patients respond to retreatment with ibrutinib or with ibrutinib plus venetoclax, so there's much less data with that combination. So really, we don't have BTK mutations, and patients respond to retreatment with single agent drugs. So patients that are progressing after completion of therapy, particularly if there's been a year or two since they've finished therapy, we shouldn't be thinking that these patients are resistant, and they'll mostly do well if we just reinstitute a BTK inhibitor and give it continuously. All right, finally, want to just really quickly touch on T-cell redirecting therapies. So this is not something I'll spend a lot of time on, but if people have questions about these molecules, we can definitely spend some question time talking about this. So, of course, these are really mutation agnostic, and the way that they're working is we've got surface targets, CD19, CD20, and we are redirecting T cells to target those and kill the B cell by apoptosis. CAR T cells are the most advanced in development. Finally, there's an approved CAR T cell in the United States, lisocabtagene maraleucel, which targets CD19. Epcoritamab is the most advanced bispecific antibody in CLL, which targets CD3 on T cells and CD20 on the CLL cell, and really is directing T cell mediated killing in a similar way to the way CAR T cells are, but of course doesn't require any ex vivo manipulation of autologous T cells. Epcoritamab is as I mentioned, in a phase 1/2 study in CLL, and there are some data that were presented at IWCLL in 2023, showing that this was a really high risk population with median of 4 prior therapies, very high risk genomics, a majority with double exposed disease. And you can see here very high overall response rates with complete response rate of around 30%. And most importantly, very high rates of undetectable MRD at a 10 to the -6 sensitivity level. So really encouraging data. Yes, quite a lot of cytokine release syndrome, which I'm not showing here, but overall a sort of reasonably manageable toxicity profile. And this is undergoing further evaluation in various combinations. What about lisocabtagene maraleucel? So this is Lysocell. This is known as Breyanzi in the United States, now approved for use in double exposed CLL. This is the progression-free survival from this study. On the left is all of the response evaluable patients. You see median progression-free survival in the black curve is a year and a half. The patients in blue are those who had a CR, and they have really excellent long-term disease-free survival. If we look over on the right, this is the double exposed subset, and they have a slightly shorter median PFS, but there are still a number of patients with really durable responses seen in this high risk group. And I will just summarize by saying really there are now numerous options to treat patients who develop BTK and BCL2 mutations. We have multiple novel ways of targeting BTK. In addition to the non-covalent inhibitor pirtobrutinib, there are a number of other non-covalent BTK inhibitors in development, like nemtabrutinib and LP168, but just didn't have time to cover everything. BCL2 mutations, we don't have yet good clinical data for targeting BCL2 again in those patients, and may not be the most rational approach, given that I showed multiple patients that also develop upregulation of other anti-apoptotic proteins like MCL1. I'll say that time-limited treatment may reduce the risk of developing mutations. We may be able to retreat patients with similar drugs after time-limited therapy. We have, as I mentioned, novel BTK treatments that can successfully treat patients with BTK mutations, and of course T-cell redirecting therapies are mutation agnostic and highly active in double refractory disease. So I will stop there, and I think I've left some time for questions. So looking forward to a discussion.
Thank you very much, Dr. Thompson, for this wonderful presentation. I'm sure all of this information will be very useful for the entire audience. And I am also encouraging them, if they have any questions, to still write them in the chat box, because we can start now the discussion. And let me start with the first question. Based on your experience, is it inevitable that sooner or later resistance to covalent BTK inhibitors will develop in most patients with CLL?
Great question. So I definitely have had patients on these drugs for more than 10 years, including relapsed patients that have been on drug for more than 10 years. In the front line, the response duration is markedly better than what we see in relapse. And particularly patients with low risk genomics, I think there may be a group of them that have really, really long remissions. Even if you look at 17p deleted patients in the front line, we're seeing response, at 6 years, we're seeing 60% of patients still in remission. So, that's from a number of ibrutinib studies. In the Elevate treatment naive study with acalabrutinib, we saw over, median PFS still not reached for 17p deleted group in the front line. And in the acalabrutinib group, we still had well over 80% of patients in remission at 6 years. So I don't. The answer is I don't know if it's inevitable that these patients will progress. We're going to have to follow them for a really long time in the front line, I think. Maybe there will be patients. I think that there will be a significant number of patients that, because of, particularly when you consider the average age of a patient when you start treatment, that there are going to be a significant number of patients that are going to only need one therapy. If you start their treatment in their 70s.
Yeah, that's true. Thank you.
But we need to consider, genomic risk, 17p deletion, complex karyotype. Have they had multiple other prior therapies? If you're multiply pre-treated and you go on a BTK inhibitor, I think it's pretty inevitable that most of those patients will relapse.
Of course. I will read another question, since, of course, we still have time. In your opinion, is there a relation between BTK and BCL2 mutation and IGHV mutation status?
So IGHV mutation status is an interesting one. Has a major influence on proliferative rate of CLL. And as a result, patients that receive time-limited therapies will progress sooner after stopping therapy if they have an unmutated IGHV. When you look at patients that receive continuous therapy with a BTK inhibitor, there is no difference in progression-free survival in really any study that's got a reasonable follow-up between mutated and unmutated IGHV. The biggest impact genomically on risk of resistance to BTK inhibitors is complex karyotype, followed by 17p deletion. With venetoclax, it's 17p deletion and complex karyotype, particularly more than 5 abnormalities, so-called high complex karyotype. So really, unmutated IGHV, I think, has less of an impact in terms of risk of on-treatment resistance with targeted agents than sort of markers of genetic instability like 17p deletion, TP53 mutation, complex karyotype. But it has a major impact on progression-free survival after time-limited therapy. Hope that makes sense.
Yeah, thank you. Actually, from the same doctor, we have another question. Is resistant mutation more with continuous compare limited duration treatment?
Yeah. I mean, I think that's very clear. If you give continuous therapy with venetoclax or a BTK inhibitor, you're going to get emergence of resistant clones. With BTK inhibitors, very clearly, BTK mutations predominantly, PLC gamma 2 mutations lesser extent. The risk of mutations is much higher in 17p deleted patients, complex karyotype patients. Same with venetoclax treated patients, more likely to become mutated if they have high risk genomics. Venetoclax, though, much more complicated resistance mechanisms, as we discussed. And as I showed, almost nobody that gets frontline doublet therapy, BTK plus ven, develops resistance mutations. And with ven plus antibody treatments, so ven obinutuzumab in the front line and ven rituximab, the resistance mutations are really rare as well. So I think my personal view is that if we take the principle in oncology that targeting multiple different pathways simultaneously reduces the risk of resistance, I think that's clearly true here. And I think limited duration therapy probably reduces the risk of resistance mutations. Now, whether a year of ibrutinib plus venetoclax is better than, say, an MRD adapted strategy like the British used in the FLAIR trial, I think that remains to be seen. So that trial has produced amazing progression-free survival results. The 6-year progression-free survival on that study is unprecedented. But no one is going to get to use the drugs like that, in their health system. I don't think. And so it remains to be seen, whether time-limited treatment and then retreatment is better than continuous treatment like they did in the FLAIR trial. I don't think we'll ever know, probably, unfortunately. But yeah, overall I'm a believer in limited duration therapy.
Mm-hmm. That's very good. And we have another question regarding venetoclax. So if the patient has already received venetoclax in the first line and the new drugs, like, for example, BTK degraders, are not available, how should we cope with BTKi resistance?
Right. So you've used, say, venetoclax obinutuzumab frontline, and then at progression you use acalabrutinib or zanubrutinib
Yeah.
and then they progress on on the BTK inhibitor, what do you do at that point?
Mm-hmm.
Yeah, good question. So,
Mm-hmm.
if you have access to venetoclax retreatment and the patient had a reasonable duration of remission after the frontline venetoclax, I think venetoclax retreatment would be a good option for that patient. If you don't have access to venetoclax retreatment, then you're in big trouble. So the data for these patients with other kind of available agents like chemoimmunotherapy or PI3 kinase inhibitors is pretty miserable. So there's retrospective data for PI3 kinase inhibitors, but more importantly, we now have data from the Bruin 321 trial, which compared idelalisib to pirtobrutinib in relapsed CLL, and there were a lot of double-exposed patients in that trial, and the control arm had really dismal results. So, I mean, I've anecdotally had some patients do quite well with PI3 kinase inhibitors in this situation, but they're difficult drugs to use. You need to be really careful with infection monitoring and the autoimmune complications that can happen, and the overall data for them are not good. So really, for those patients, you've got to try and get them on a clinical trial. If you don't have access to pirtobrutinib, try and get a clinical trial. Otherwise, ven retreatment or last resort PI3 kinase inhibitor or chemotherapy.
Yeah. Okay, thank you. And I think we have time for a couple of more questions. So the next one, what is it, in your opinion, the role of the microenvironment in the formation of the BTKI resistance in the end?
Oof. Won't profess to be an absolute expert on this, but in general, microenvironment very important for the growth and development of CLL cells. It's very complex. Lots of different cell types involved. Do microenvironmental interactions cause BTK inhibitor resistance? I don't know that that's the case. I think they're mostly genomic events that occur within the CLL cells. And so I don't think that necessarily the microenvironment plays a huge role in sort of specific therapy resistance in the setting of those targeted agents. I think that it probably plays a bigger role in sort of maintenance of MRD in the setting of things like venetoclax therapy, for example. I think that cells within microenvironmental niches, particularly the lymph nodes, I think they're protected from BCL2 inhibitor mediated death, which is why we can easily kill all the cells that are in the blood and achieve undetectable MRD, but patients are not always in complete response and they often relapse later. So I think and certainly when you look at CLL cells grown on stroma, there's upregulation of other anti-apoptotic proteins and things that happen. So I think that's probably, that microenvironmental interactions play a bigger role in probably some of these complex venetoclax resistance mechanisms, more so than BTK resistance, where it's predominantly single gene mutations. And then the other thing to say about the microenvironment is that I think it has a major impact on immunotherapy responses in CLL. So with liso-cel, the data that I showed you saw that the complete response rate's only 18%. That's dramatically lower than what you see in diffuse large B-cell lymphoma, and in particular other indolent lymphomas like follicular lymphoma, where the complete response rate's in the high 70s. So really night and day. Why is that? Well, CLL patients have these absolutely messed up T cells. So when you look at their T cells in the lab, they and there's a beautiful Nature paper in 2018 by the University of Pennsylvania group. I think Freyetta was the first author, where they just showed huge numbers of really exhausted, terminally differentiated T cells in the apheresis product of the CLL patients that they were making CAR from. And so, how much of that is due to the how much of the poor CAR response is due to the actual product compared to, inhibitory effect of the microenvironment when you put the cell back in the patient? I think maybe still to be worked out, but I think immunotherapy in CLL has been problematic because of the peculiarities of the CLL microenvironment and the impact on T cell function. But that having been said, the bispecific antibody responses seem to be pretty good, better than I might have expected.
Yeah, thank you for sharing your opinion. I think it's very important to ask also these questions, also regarding microenvironment, because I'm pretty sure it is quite important.
Well, it's very topical. The question is, what do we do about it?
Exactly.
So it's one thing to kind of postulate that it might be involved in resistance, but which cell type in there are you going to target? People have sort of tried to target kind of myeloid-derived suppressor cells and other things like that, and it ends up being it's very hard to design clinical studies based on
right.
It doesn't seem to be a magic bullet. That's whenever I go to a microenvironment basic science talk, that's my immediate thought. I'm sitting there thinking, how am I going to design a trial? Like which cell am I going to target? It's hard.
Yeah. So thank you very much. I think we are running out of time. However, there are not any more questions. So let me thank you once again for this amazing lecture and for this interesting discussion. And let me also wish you a very good luck in your career and a good night for you in this case.
Thanks so much for having me.
Thank you very much.
Okay. Bye.
Bye.